Good afternoon, Assalamu alaikum. Dr. Abid Rafiq here, and today is the 2nd of July 2020. Today topic is epilepsy in children, and it's quite exhaustive presentation, and also topic is quite difficult to understand, especially having said that there are plenty of advancement in this field. So I thought maybe it's better I can do some video elaboration of some slides, and rest of the things you can just read from the slides. So I will try to finish the slides quickly. Any question you can let me know on the emails or WhatsApp. So what is convulsion? Is a transient occurrence of signs and symptoms resulting from abnormal, excessive, or synchronous neuronal activity in the brain. And this involuntary disturbance of brain function that may be manifested as an impairment or loss of consciousness, abnormal motor activity, behavioral abnormality, sensory impairment, or autonomic dysfunction. Seizures, they are quite common. Almost 3 to 5% of kids they can have in their lifetime, and they can be both febrile or afebrile. So, what is epilepsy? Epilepsy is a recurrent seizure unrelated to fever or to any acute cerebral insult. So, seizure because of epilepsy, they should not be because of fever or because of any acute cerebral insult like meningoencephalitis. So, they should not be because of those causes. They should be having a afebrile convulsion and recurrent. So, that's the definition of epilepsy. Etiology, actually epilepsy is very quite common in pediatric age group, and that's a quite common neurological issue. Almost 1% children they can have in their lifetime. And the problem with epilepsy that 50%, almost 50% children, they don't show the cause. So you don't know why they are convulsing, and that is the problem, especially in the prognosis and counseling the parents. Okay, what you can tell to the parents that why their child has this problem, and obviously most of the time you may have to give them drugs. So it's very difficult area to counsel the parents that where you don't know that why epilepsy is happening. But in any event affecting the brain can result in epilepsy in the long term. Causes of epilepsy, the most important thing what you need to remember, the most common cause is static or non-progressive encephalopathy, which we call it CP, like cerebral palsy. And it is most likely because of perinatal event, hypoxia, hemorrhage, or any CNS infection like meningitis in the newborn age, head trauma, or any developmental defects of the brain. There are other rare causes of epilepsy like tuberous sclerosis or neurofibromatosis. Brain tumors can give you epilepsy, and also there are some degenerative and inborn errors of metabolism in children which can give you epilepsy. And these epilepsy, they are mostly symptomatic. So symptomatic, where I use the symptomatic epilepsy word, that means that patient require treatment, because sometimes epilepsy is benign, sometimes it is intermediate, and sometimes it is very severe which need treatment, and even sometimes you cannot control the convulsion on multiple drugs, not only on one drug, you have to give multiple drugs, and there is a drug interaction we will discuss in detail. So that is the difficult area. So if we talk about that, what is symptomatic epilepsy and what are the risk factors? So if the child has normal development with the normal neurological exam, and there is no brain injury, and there are characteristic EEG abnormalities like in uh, uh, Fatima or absence epilepsy, will get the characteristic EEG will show you, that is spike and wave 3 hertz pattern. If you diagnose like this, then most likely the epilepsy is benign. Even if you require treatment, maybe in the long term baby will outgrow the epilepsy and you can stop the treatment. But symptomatic epilepsy, What are those? If the developmental delay, there is a history of brain injury, abnormal neurological exam, so then these patients, they are the worst one, need treatment, also long-term treatment, and may need multiple drugs. So lot of time parents, they ask you question that after first convulsion, what is my chance of having a second convulsion, and that is very important. So almost 1/3 of patient, they can have another convulsion. अगला सवाल पेरेंट्स का ये होता है कि ओके, इफ़ यू are starting my child on epileptic treatment, that how much chances they can outgrow this disease, or you can stop treatment in the long term. So your answer will be almost 50% patient, half of the patient in the long term you can stop drugs. Even if you have to start drugs, you can stop later on if they are fits free, like for the next 2 to 3 years. So the answer to this question, half of the children, they can outgrow their epilepsy. And obviously if one should withdraw, वो आपसे, they might be asked this question कि if we are stopping the treatment or reducing the treatment, because obviously you don't want to withdraw suddenly, you will reduce the treatment, and they can ask you कि डॉक्टर हमारे बच्चे को कितना रिस्क है कि उसको दोबारा ये ट्रीटमेंट देनी पड़ सकती है, या अगर आप उसकी दवाई आहिस्ता आहिस्ता कम कर रहे हैं तो उसकी दवाई को दोबारा बढ़ाना पड़ सकता है. तो उसका जवाब ये है कि 30% पेशेंट्स को ये ज़रूरत पड़ सकती है. These 3 points are very important in the counseling of the epilepsy while you are talking to the parents. So pathophysiology of convulsion is very simple, and I put this slide deliberately that I want to tell you that how seizures happen. So seizures happen because of imbalance between the excitatory neurotransmitter, which is glutamate, and inhibitory neurotransmitter, which is GABA. So once there is imbalance, and what happens whenever there is any convulsion in the body, initially glutamate concentration rises at the synaptic area, and then later on there is a GABA release, which is inhibitory and try to stop the convulsion. But if there is imbalance and seizure threshold will be less, then glutamate can take over the GABA and convulsion can happen. And even if you see in the next slide, that because of some reason, if glutamate excitation will take over the inhibition of GABA, then the child can have status epilepticus. So what is status epilepticus? Status epilepticus is any convulsion lasting more than 5 minutes. So you can imagine how important it is for doctor to stop convulsion once child started convulsion. So अगर वो 5 मिनट से ज़्यादा कन्वल्स करेगा बच्चा, तो देर इज़ अ सिग्निफिकेंट ब्रेन इंजरी which obviously will cause more convulsion. So it's a vicious cycle. अगर किसी बच्चे को convulsion हो रहे हैं and child you cannot stop that convulsion, then there is a more brain injury, more excitation by the glutamate, and there is a more chances of getting into that problem like status epilepticus, and the prognosis will be poor. So to summary, you have to stop the convulsion as quickly as possible, and obviously there are different drugs which you will use if a convulsion is going more than like 1 or 2 minutes. Definitely then you have to give those drugs. So it is important. And what happen in these patients who has convulsion? Because there is a prolonged excitation by the glutamate, and obviously inhibitory neurons, they have dysfunctional and they cannot inhibit the convulsion which is going on, and it is also affected by tumors and brain injury. So how you will evaluate any patient with epilepsy in pediatric? It's a clinical diagnosis. History and physical exam is very important. I deliberately put all these points. History point, age of onset is very important, because you can, the most important thing in the diagnosis of epilepsy is to diagnose the class of epilepsy. कि आपके बच्चे को obviously we will discuss the classification of epilepsy in detail in the next couple of slides, but important thing कि आपने उसको ये देखना है कि एपिलेप्सी the child is suffering which kind of epilepsy, like is it a generalized or is it a focal epilepsy, and also that you can pinpoint with the age of onset, duration and frequency, how much convulsion lasted for how many minutes and how frequent it is, factors provoking the convulsion, is there any aura, and whether the seizures they are focal or generalized, and what about the post-ictal state, and any drug history, or how is the developmental status of the child. Physical points in evaluation of epilepsy always exclude organic cause. What does it mean here? Mean always rule out that child is not suffering of any like meningoencephalitis or brain tumor, and you have to take the head circumference, look for facial dysmorphism, full neurological exam including developmental assessment, and also look for cafe au lait spot or hypopigmented patches. Cafe au lait spot you can find in neurofibromatosis, and hypopigmented patch you can find in tuberous sclerosis. So these are the two neurocutaneous syndromes which can present in children with epilepsy. And also look for fundus, especially for chorioretinitis or papillary edema. So these are the examination pertinent points in pediatric. This slide is not good, but just I want to show you in the pictures that what is the difference between. So this is a partial fits and this is a generalized, and you can see in generalized fits there is a brain activity excitation goes in both cerebral hemispheres, and how it, and that is the reason child suddenly get loss of consciousness, and there is a abrupt cessation of any activity, while in partial, while in partial you can see there is a small point in brain. Partial can be simple or complex partial. Simple means child retain consciousness, and complex means child loses consciousness. And even some child they can have generalized convulsion, but initially to begin with they might have simple partial or complex partial, and then they can generalize convulsion. So these both they can overlap. So this convulsion in the beginning, and then the same child can have generalized convulsion, and partial divided into two, simple that means child retain alertness, and complex means child loses consciousness, which is characteristic of generalized. And in the generalized you can see myoclonic, tonic, atonic, absence or tonic-clonic. These are all types of generalized convulsion. I put this slide just to show you the difference in the EEG, and how you see the small focus and there is a generalized focus, and that this generalized activity in both cerebral hemisphere impairs the consciousness of the child, and you can see the EEG difference also in between the both convulsion. Epilepsy types, this we have just discussed now. Partial can be simple or complex, and it can also go into the generalized, which generally is a loss of conscious level. You can see this is a normal EEG, and how the EEG abnormal in the generalized seizure patients. This is very exhausting classification, but just to complete, just you have to remember the major two types: the generalized and the focal. And focal has some types, and generalized epilepsy has some types. The most important types in the generalized is the absence convulsion and generalized tonic-clonic convulsion, which we call it grand mal epilepsy, and also generalized can be myoclonic epilepsy. So these are the three major types of generalized. In the focal you can be aware or impaired awareness, and that means focal can be simple or complex, and then you have a motor or non-motor element in the focal. And focal convulsion they can lead to the generalized convulsion as well. There are some epileptic syndromes just to complete in pediatric, and the most common the West syndrome, we call it infantile spasm, poor prognosis, and also there is a Lennox-Gastaut syndrome. Also these patients they have mental retardation and characteristic EEG findings, and they don't have good prognosis. We discussed that one in the last slides. These are the two major types of convulsion. So childhood convulsion, I mean, normally they can present at any age, but this is the most common age. 2 to 12-year-old patient, mostly they can have convulsion. And obviously, if repeated convulsion, we call it epilepsy. They can be benign, intermediate, or catastrophic. Means mostly these patients, they have developmental regression and they have developmental issues. Intermediate, mostly benign, they don't need treatment, and they are to have a good epilepsy. We'll discuss that one. And intermediate, normally they are having a normal development, but they have abnormal EEG, and they have normal MRI mostly, and they have good prognosis, and normally they need 2 to 3 years of treatment, and then you can think over it about reducing and stopping the treatment. Because the most important question for the parents and for the physician to answer this, that okay, we are starting some treatment, how long my child is having this treatment on. So that is the most important, and you need to tell parents that okay, your child fall in this category, and depending on our future assessment and the how child does with these anti-epileptic drugs, we can decide about that how much time your child going to need the anti-epileptic drugs on. So we'll discuss just quickly about the individual convulsion. Generalized convulsion, we told they already involve the whole brain with the abrupt arrest of activity with loss of conscious level, and they have tonic-clonic phase and post-ictal state. Grand mal epilepsy is type of generalized convulsion, most common convulsive disorder, and it is generalized tonic-clonic convulsion, and it has overall good prognosis, but normally you have to treat these patients with the drugs. Absence convulsion, they also called Fatima seizures. They consist of brief episode of altered awareness during which child may appear to be daydreaming. All motor activity stops. Child suddenly stays blank or blinks rhythmically and does not respond when touched or called by name. But this lasts for very few seconds and it can recur again and again. I mean, this is the typical example of absence seizures. So they basically just stare for a few seconds. And absence seizure obviously quite common in generalized convulsion. And generalized convulsion, you know that they lost consciousness, and overall prognosis is in Patimal or absence seizure, very good prognosis overall. This is absence seizure with also eye movements, you can see here, and this is myoclonic absence. The child has a this is not the video, just a picture, but this child hand will show the myoclonic jerks, and child suddenly stops activity. You can see the difference between the generalized epilepsy and Patimal epilepsy EEG difference. This is the characteristic, we call it spike and wave 3 Hertz pattern. And in grand mal epilepsy, you have high amplitude and multiple spikes and wave discharge on EEG. Partial convulsions, we just a brief that we know that they can be simple or they can be complex. Mostly they have jerking, muscle rigidity, spasm, head turning, unusual sensation, memory or emotional disturbances. Also you can see automatism in complex partial, lip smacking, chewing, walking or other repetitive involuntary but coordinated movements. And obviously mostly they retain their consciousness in the simple. Obviously they can lose in the complex partial convulsion. So if you see the EEG, it will be like this. In complex partial seizures, you will see the intermittent spike and wave pattern with normal activity in between. So benign Rolandic epilepsy, This is the best epilepsy to have and the highest chance of outgrow the disease in the long term. And normally they don't need treatment. Age group is like around childhood age, simple partial seizure, usually during sleep, and they have characteristic pattern on EEG, and they have very good. Also, we call it Jacksonian epilepsy. And if you find this clinical presentation with characteristic EEG pattern, you can counsel the parents. Okay, mostly your child will not need any treatment, and even if there is recurrent, we can start treatment, which is ethosuximide. Sorry, not the ethosuximide. You will start because it's a benign epilepsy and it's one of the form of focal epilepsy. So you will start from benzodiazepine like carbamazepine. Ethosuximide is for the Fatima convulsion we will discuss in future. So mostly these patients they don't need treatment. Epileptic syndromes, there are they are rare, but they don't have good prognosis. We'll just discuss. One of them is the infantile spasm or West syndrome. Small kids, and they have head turning and smacking movements. Slam, we call it slam spells, and they have developmental regression. And EEG has a characteristic Hibbs arrhythmia pattern. And infantile spasm has a poor prognosis, and you can try ACTH or prednisolone, and these are small kids. Lennox-Gastaut syndrome has a triad characteristic. They have characteristic akinetic seizure with mental handicap, and there is also characteristic pattern on EEG. And it's a severe disease, and prognosis is not good and need multiple treatment drugs. Landau-Kleffner syndrome, they have autism, serious language deterioration, and behavioral issue, plus there is a convulsion, and prognosis is not good. So this is a diagnostic workup for any convulsion. But if you suspect that child has a repeated convulsion, then obviously you will do the EEG, because EEG will tell you that which kind of epilepsy you have and what kind of treatment, if patient need, you will start. But the problem with the EEG, it needs special expertise. It is a time consuming, and also mostly even if you do EEG and in between the patient is normal, you might not get the EEG pattern. Sometimes you have to give some stimulation, like you have to ask patient for hyperventilation, or you have to do some photostimulation to induce a convulsion while you are doing that test. So there are limitation of EEG also, and mostly in 30 to 40% cases you will get EEG positive. Still, you can have a normal EEG with a history of recurrent convulsion, and then obviously you have to decide depending on what type of convulsion and what is the description of convulsion parents they are telling you. Also, you need to do especially the MRI if you suspect that you are dealing with a symptomatic epilepsy. Management will discuss very quickly. Majority of cases you can control convulsion and you can reduce in frequency. And success of therapy depends on severity of the seizure disorder, compliance with the medication, and monitoring of the blood levels of the drugs by the physician. There are plenty of drugs, like 5 or 6 class of drugs. Each of the drug is useful in specific types of convulsion, and there are side effects which you need to monitor. Always start with the one drug. Finding the proper medication and correct dosage level takes some time. And there are some surgical option which is out of our there are surgical option and ketogenic diet and other plenty of options to treat symptomatic epilepsy, but I think those are out of scope right now. So treatment should be start with a single anticonvulsant. The dosage should be slowly built up until seizure control is achieved. And obviously, if you have achieved one drug dose highest and still you are not getting success, then you can try a different drug but don't stop the first drug, you have to withdraw slowly. Combination therapy is very rare to use and need a special neurologist opinion. We'll discuss quickly now about the choice of drugs in different types of epilepsy. Mostly, I mean, this table is might be confusing for you, but just to remember that you can treat any kind of epilepsy with valproic acid. Remember this formula. You can use, if you obviously first you need to decide whether you need to use the drugs or not. Maybe child is suffering of having a benign epilepsy, just counsel the parents. But if you feel that you need to start drugs, then for any kind of epilepsy you can start with valproic acid. But remember, there are some age limits. In small babies, you don't start valproic because it has a hepatotoxicity. Generally, valproic is a drug of choice for any kind of generalized epilepsy. But for Fatima, initially you can try ethosuximide. That is a drug of choice. For focal epilepsy, you start with carbamazepine, and then you can switch to valproic if you don't have response. So again, in brief, if you have a focal, then carbamazepine. If you have a grand, then valproic acid is better. Myoclonic, again valproic acid. Infantile spasm, steroids, and in psychomotor or temporal lobe epilepsy, you can first try with the carbamazepine. Epilepsy care is important, especially for the family, and you need to do the proper family education before you discharge the patient from the hospital or in the clinic. Especially make sure the child is well supervised in the bathroom, tub, beach or swimming pool. Teach the child to recognize the sign of impending seizure or seek help. Medical bracelet can be helpful, and most importantly, child continue to take medication at the prescribed doses even after convulsion they are under control. The doctor may recommend tapering off the medication after the child has been free of convulsion for 2 or more than 2, like 3 years, but close medical supervision is needed. So, okay, so this is the end of lecture, and now you guys can do your quiz, and I always give you the time, and also I don't hide my answers from you people, because I know that you guys are now very mature and going to be doctor very soon, and I would expect that at this level you will be honest with yourself. So what I normally ask, or what I expect from you, that you will take a paper and then all 5 questions you will do, and you will write your answer. Then at the end of your quiz, you can see the answer, and I think that will help you your thought process. Thank you very much, and please feel free to ask any question.